Good afternoon, everybody, and very welcome to all my faculty delegates. And we are privileged and honored to have our president, IFS today, Dr. Pankaj Talwar sir, with us. This is our second series of a webinar from SIG Reproductive Endocrinology. Here, what are trying to do is we have made around 10 topics, subtopics, and we're trying to cover all of them. In the last webinar, we discussed about medical conditions like thyroid and also menstrual disorders during puberty and adults. This time, we have now progressed to our stimulations and trying to understand the basics first, how to make it safe and successful, and anything we can do before the start of the treatment to make it more successful. So that's the aim of this webinar, and that's what the name suggests, making it more safe and successful. So without much delay, I would like to now go ahead and start my webinar. At the outset, I'm going to introduce my guest of honor, uh, President IFS, Dr. Pankaj Talwar sir. He needs very less introduction, I would say,
Don't
but
bother. Please
I'm
don't bother.
still honored to
Thank you, Puneet.
any kind of introduce him. Let me do, sir.
No, thank you, Puneet. Not needed. Actually, not
Thoda sa,
needed.
sir.
It's a family. It's a family. We all know each other. It's a very
So
small
please.
country. India has become a very small country now. But thank you so much, ma'am, for inviting me here. And I'm proud, privileged to have under your aegis this meeting being done. I can see Dr. Renu, Dr. Asha, Dr. Aarti is there. So great friends and so much of nostalgia I get seeing you all on the screen. And this topic is very dear to my heart and in fact for everybody's heart. So I won't hold people from moving on to the topic for the day. But before I move on, I will tell people that we have got at IFS we have got a pan-India presence with around 29 chapters. We've got around 4,600 members all over the country presently. Very fast growing body we have. And we got many SIGs, and SIGs are meant to inculcate, generate interest in the people to learn more about a specific field. And this SIG is a very, very nice SIG, which is being headed by Dr. Abha as the mentor. And that speaks a lot about the way it will grow. And the convener is Dr. Puneet, a very astute clinician, and my younger sister. And then we have Rajapriya, who's here, and Dr. Kokila Desai are the co-conveners. This will bring you how the things are. And today's faculty is super faculty, Dr. Renu, Asha, Aarti, Nisha, Niru, and Dr. Leena Vadva. So as we move on to the topic for the day, I've been told to speak only a few lines before Puneet will make me muted. I'll only tell you that when we talk about endocrinology, we talk about the reproduction. What comes to our mind is few bunch of hormones, LH, FSH, testosterone, and we keep juggling with them along with some high-end investigations. So my message to you all will be very simple, that please keep hormones at the second line. What we are forgetting is the primary clinical diagnosis. So we are, suppose it's a male or a female, we are going to AMH straight away. We are going to doing FSH, LH, and multiple complicated inhibin B. So try to keep it as clinical as possible. Have a clinical diagnosis and confirm with the endocrine by the diagnosis by the hormones. That's very, very important. Keeping it simple not only will keep our cerebrum activated and we'll be able to apply what we have learned long time back in our practice, but also save patients their money. They will save a lot of money by not doing unnecessary investigations. So Puneet, that's my message for everyone, to keep it simple, safe, and economical. Ours is a growing economy. People are not very affording, and majority of our tests are not covered as a part of any TP or these things. So we should try to keep it more clinical oriented and economical for the people. So thank you so much for this opportunity, and I wish this meeting all the best. And I'm sure that under your astute leadership, Puneet is gonna be rocking, and we'll be putting it on the YouTube. So all the people who have missed it, it'll be on the YouTube for coming decades, and we can watch it there. And I'm sure that is gonna hit minimum 1 lakh likes or views within a month or so. Thank you so much, Puneet.
Thank you. Thank you so much for your kind words, sir, and blessings and best wishes. I hope we continue to impart knowledge, awareness, and I think that's what has been one of the dreams of Pankaj sir as well. And there is now a specific YouTube channel only for patients also. So to bring in awareness not only to our own faculty, own colleagues, and learn ourselves, but also to our patients who are equally partnered with us in this journey. So thank you so much, sir. Thank you for being here and giving us a kickstart to start this session. Right. So I would now like to proceed with our academic session and introduce and welcome our chairpersons for our first session. I would like to welcome Dr. Asha Rao. Dr. Asha Rao is a director of Rao Hospital and Care Center, Coimbatore. She's a director for postdoctoral fellowship program in reproductive medicine and endocrinology. She's a chairperson. She has been the chairperson of Endometriosis Committee FOXY 2020-2023 and past president of Coimbatore Obs and Gynae Society, and lot many other accolades to her name. She's got publications and research in various journals and also contributed various chapters in the books. She has received gold medal from President of India and from university in the final MBBS and has delivered the first ICSI baby of Coimbatore in 1998. Very proud of you, Dr. Asha Rao, ma'am, and welcome to this webinar. And we welcome to hear from you your expert comments also on this topic. My next chairperson is Dr. K. Arati. She's a managing director and lead consultant. Manu Hospital. She's a center in charge of CMAR Coimbatore, joint secretary of IFS Tamil Nadu chapter. She's received Young Talent Award and Dronacharya Award from ISAR 2024. Very welcome, Dr. Arti, and we look forward to hear your expert comments on this topic. I would like now you both to introduce our first speaker of the day, Dr. Renu Mishra, ma'am. Thank you. Over to you.
Thank you. Thank you so much, Dr. Punita, for these kind words. And it is such a pleasure to be here today and meet all the galaxy and my dear friends. President IFS Pankaj Talwar, Sunita Mitchell, and the excellent speakers. And you have got a very well-structured program. And it will be very nice to meet Abha later. And the first topic will be delivered by none other than Renu Mishra, an illustrious person. She's the director, Tamna Fertility and IVF Center, senior consultant in obstetrics and gynecology, Sitaram Bhatia Institute of Science and Research, and she's an additional professor of AIIMS New Delhi, an excellent endoscopic surgeon, and she's also specialized in infertility. She's the founder president of Hysteroscopic Society, and she has done so much work in this field of infertility and ART. We're all waiting to listen to her on her expertise, on her expert talk about hormones prior to ART. Dr. Renu, please.
Thank you, Dr. Asha. We'll just share my screen. Thank you, Puneet, Dr. Rajapriya, Dr. Kokila, for giving me this opportunity. I really feel honored to be part of this SIG on reproductive endocrinology, because if you look at IVF cycle, I feel the cerebral part is the endocrinology and the rest is spinal. Although, having said that, I do not mean that we should be doing unnecessary tests like Dr. Pankaj Talwar just endorsed. So we need to keep it simple. But yes, that's the brain behind IVF. So today's topic is pre-treatment hormonal therapy in IVF. So where do we need to give any pre-treatment, or where do we think that something is required before we actually start the IVF cycle? Number one is scheduling the cycle, particularly in people who do batch IVF, or sometimes in even PCO patients where cycles are so irregular, you don't know when is she going to bleed, and you want to have some idea when are you going to start the IVF cycle. The next is to synchronize the cohort. In PCOS patients, we know that there are a lot of follicles, but very asynchronous growth. And at the same time, in poor responders, very few follicles and asynchronous growth. So this is even worse. So we cannot increase the number of eggs, but if we can synchronize in some way the cohort, we may get a few more eggs, which is so precious in a poor responder. Of course, some conditions, which I will not go into too much details, is gynecological conditions which impact IVF cycle. They're not directly part of the IVF cycle, but they definitely impact the outcomes of an IVF cycle. And can we do something as a pre-treatment to improve our pregnancy outcomes or live birth outcomes? Can we give some pre-treatment? So the most common out of these conditions is fibroids and endometriosis, which we all know will increase with age, with infertility. So somehow we see more and more of these as we get more older patients. So type 1 and 2 fibroids, which means that there is a submucous component in the uterine cavity, is detrimental to implantation. And either we do surgery or we can push the fibroid out of the cavity for the time being and go for IVF, then you can actually avoid a surgery. So in that scenario, people have used ulipristal. Mifepristone, I could not find much studies, but I have tried myself in 1 or 2 patients. And endometriosis, again, endometriosis, adenomyosis, now there is data to show that if you pre-treat them with Dynogest or GnRH analogs, which you have been doing earlier, then it may improve the chances of pregnancy. Sorry. So scheduling the cycle, well, combined pills we have used from time immemorial. And I will go in details about this. And the other option we have is to use GnRH analogs, which you can either start on day 21. And the beauty of the long protocol is that you can actually then, it's a very flexible protocol. You can then start stimulation whenever you want, depending on some rough planned time for egg retrieval. In PCOS patient, you can combine both. You can give pills and then overlap them for 5 days with GnRH analog, and then continue GnRH analog as in long protocol, and then you can start stimulation as you want to plan the retrieval. So combined pills for scheduling. Most commonly used prescription we've been using for ages for scheduling, and also it may help with suppression of high LH and androgen levels in PCOS. But also these are the ones which have seen the biggest turmoil. In the last 2 decades, it's gone up and down. You know, we've heard all kinds of things about pills. Pills were good, then pills became bad because they reduced pregnancy rates, and then probably there's a little U-turn now. So this was a study published in 2000 where still the old concept seems to hold, as it said that anovulation induced by oral contraceptives favor pregnancy during the following 2 menstrual cycles. And they showed that if you give pills and then do IVF, it may improve pregnancy. In fact, this concept is so old. I remember when I was a postgraduate, we didn't have IVF at that time. We didn't even do IUI at that time. But in PCO patients, which have always been in India, you know, so common, we used to give 1 or 2 cycles of contraceptive pills. And many times you saw that there was a rebound ovulation in the subsequent cycle and patient got pregnant. So we've grown up with this idea. But, sorry. In 2000, we found that things started changing. This concept, we were told that was bad, that what we've been doing is not the best thing to do for fertility and IVF. So this was a paper published, this was a meta-analysis published in 2008 by Geisinger, which is the famous Taladze's group from Greece. And they showed that pregnancy rate, although was not affected, but the duration of gonadotrophin stimulation and gonadotrophin consumption were increased if you pre-treated them with pills. 2010, the same group updated their their meta-analysis, and now they went a step further and they said the pregnancy rate was found to be significantly lower in patients who were pre-treated with oral contraceptive pills. And in 2017, this Cochrane data review, which included 17 trials and studies from 2002 to 2011, they concluded, the conclusion said that the rate of live birth or ongoing pregnancy was lower in the pre-treatment group. And this was the sort of the final nail in the coffin. And we all stopped using, or we were told that, okay, don't use more than 12, 14 days, maximum 15 days of the pill. And then again, we started seeing a little U-turn. In 2019, this was a study published which said effect of oral contraceptive pre-treatment on IVF outcomes in women who were following the agonist protocol. This was a big study, 2,000 women. And what they concluded from the study was that there was no significant difference in clinical pregnancy rate, whether it was live or fresh embryo transfer. So at least they said, if you give pills, it does not reduce the pregnancy rate. So one notch up. And this was another study where they showed that live birth rate after fresh transfer was significantly lower, but the live birth rate after frozen cycles were similar. The next study, 2020, I've just picked up the big studies, but I have done a thorough research, thorough literature search. And what I'm showing you is the gist of what I found in different articles. So this study, patients were categorized into two groups, one which had pills for pre-treatment and the other did not have. And they showed that the use of OCP was independently associated with a small increase in number of oocytes after adjusting for age, BMI, and use of pills. So this was now going little positive for the pill, that the number of eggs retrieved were a little higher. And then they said that OCP administration for 12 to 30 days with a washout period of 5 days does not affect clinical pregnancy rate, live birth, or cumulative live birth, which meant that both fresh and frozen transfer, there was no deterioration in pregnancy rate. Although they did show that the oocytes collected were more in the pill group. The next study, this was again a large study from China, 2,000 cycles. And here they showed that the number of oocytes and number of blasts were higher in the OCP group after adjusting for age and AMH. But again, they showed that pregnancy outcomes from euploid frozen blastocyst transfer were same. The other conclusion which they showed was that it may be beneficial in younger patients with higher AMH or in PCOS patients. The pill treatment may actually give a little higher pregnancy rate, but overall in the cohort, they did not show any difference in the pregnancy rate. So in PCOS patient, if we now see per se, then the problems with PCOS patients, we all know: irregular cycles, difficulty in scheduling, asynchronous growth, high androgen levels, high LH levels. And what do we give for pre-treatment? We can give pills, agonists, progesterone. And this was now a paper from 2015, which said successive and cyclical oral contraceptive pill treatment improves IVF-ICSI outcomes of PCOS patients. So this showed that it reduces the hyperandrogenism and the antral follicle excess and actually improves pregnancy rates if you looked at the subgroup of PCOS patients. So in these patients, certainly does not seem to do any harm. It may be beneficial to give some pills for suppression of the LH and androgens. So if you want to summarize the pre-treatment with pills, then pre-treatment with pills does not affect pregnancy outcomes. At best, we can draw this conclusion that if it does not make it better, it does not make it worse. But prolonged COC suppresses FSH-LH, and you may need more days of stimulation and consumption of gonadotrophins. And in the PCOS subgroup, it may actually be beneficial as it gives higher egg retrieval and higher pregnancy rate in some studies. What about pre-treatment in poor responders? So this is a very frustrating group where people have tried all kinds of interventions, pre-treatment and co-treatment. So pre-treatment, what we have tried is estradiol, DHEA, testosterone gel, GnRH antagonist, and progesterone. So if we see this, this was a very nice review articles were published very, very recently, 2024 September, where they looked at all these interventions and went into great details whether there was any benefit of this pre-treatment or not. And what they showed was that pre-treatment with DHEA and delayed start with GnRH antagonist, that is, you give a few days, 5 to 7 days of GnRH antagonist and then start the stimulation, may increase the number of oocytes retrieved, but does not make any difference in the live birth rates. So overall, does not seem to help you, but although the number of oocytes retrieved were more in these patients. What about estradiol pretreatment? Estradiol pretreatment also in this study, they started on day 7 after ovulation. That means in the luteal phase, 1 week prior to the menses, they started 2 milligram twice a day until day 2 of their next menstruation. But they found no significant difference either in the number of oocytes retrieved or in terms of pregnancy outcomes. So estradiol, although some small studies have shown some benefit, but overall does not seem to do any wonders, does not improve pregnancy rates. People have also looked at the duration of estradiol valerate, and some people have even given up to 10 days after starting the period. I mean, into the cycle where you are doing stimulation. And though there was no advantage, there was no disadvantage also. But overall, the intervention does not seem to work. So another study where estradiol was given again started in the luteal phase for 10 days. And FSH was started after 1 day of gap, 1 day washout period. And this same conclusion was found that there was no difference in live birth after fresh transfer or cumulative live birth rate, although the stimulation could be longer because of suppression due to the estradiol on the FSH. So may require higher dose and longer stimulation, but did not make any difference to live birth rate. What about testosterone pre-treatment? Well, this is the only one which has shown some promise, and some studies, good studies have shown that may improve pregnancy rates. And this was a study published in 2021. So infertile women with poor ovarian response, they were classified, they were actually divided into 3 groups. One group got pre-treatment with testosterone gel, 1%, 12.5 grams daily for 4 weeks. Another group got for 6 weeks. And the third group was control, which did not get any pre-treatment. And they found that the clinical and ongoing pregnancy rates were significantly higher in the testosterone gel pre-treatment group. So this may be helpful, although there was no difference between the group where testosterone gel was given for 4 weeks or 6 weeks. So that means giving for a longer duration does not increase the benefit. So even 4 weeks is enough. Some people have given even less. Coming to fibroids, so like I was saying that if there is a submucous component, there is always a question, how do you transfer without doing surgery, because this can interfere with implantation or may cause miscarriage. So this was a case series, 26 patients, where ulipristal acetate 5 milligrams per day was given for 1 to 3 courses. So one course is 12 weeks, and then you give a washout for 1 month, and then you can give another course. Most people did not get more than 1 or 2 courses. So how many courses you get depends on the ultrasound evaluation, whether there is still a submucous component or not. And after that, once the submucous component was not there, they underwent IVF, and there was a 50% pregnancy rate, which was similar to the control group, where there was people having IVF, similar group, but no fibroids. So it looks promising, because once you do a myomectomy, then the question arises that you cannot do a transfer for maybe 3 months or 6 months, depending how deep it is into the myometrium. What about endometriosis? That is also becoming a daily problem for us. So I have not, there are studies for all this, but to cut short the time, I did not mention all the studies here. But this also, there are studies to show that there is improved pregnancy rates with IVF when Dynogest was given compared to women who underwent surgery for endometrioma. So again, patients were given Dynogest for maybe 3 months or 6 months, depending. And then they underwent IVF and they found that the rates of pregnancy were improved in the Dynogest group compared to the surgery group. Another area where the studies have been done is post-operative suppression with Dynogest or GnRH analog. We've been doing with this for a long time. After operating for an endometrioma, we give GnRH analog and then proceed for IVF. But now there are studies to show that Dynogest can do the same job. And if you put patients on Dynogest or analogs post-operatively and then proceed for IVF, then you get a better pregnancy rate. This was a nice study, so I thought I will tell the detail about this. So this was 151 women with previous failed IVF cycle and all in fresh and all subsequent embryo transfers. 58% of these patients, that is 88, underwent IVF without receiving hormonal treatment, and 42%, that is 63 women, received 3 months of either 3 months of Dynogest. So cumulative implantation, clinical pregnancy, live birth rates were all significantly higher in the Dynogest treated group. And the largest diameter of endometriomas was significantly decreased. And more so, there was a significant increased number of oocytes which were retrieved, 2 PNs and blastocysts in women with endometriomas of diameter more than 4 centimeters. So who had earlier endometriomas more than 4 centimeters, when they were put on Dynogest before IVF, they actually had more eggs and more blasts that could be achieved. So adenomyosis, of course, this is very standard. We are doing segmental IVF. We do embryo transfer after Dynogest or GnRH analogs, and that is very well known, very accepted. So just to summarize, pre-treatment in poor responders have generally failed. Some promise has been seen by testosterone gel. Pre-treatment with ulipristal for type 1 or 2 fibroids may obviate the need for surgery before IVF. Here, I would just like to mention, a lot of people are very, very scared about ulipristal. I've used it in quite a few patients. It works very well. And I actually thoroughly searched literature before I started using ulipristal. It is no more banned. And in fact, European Medical Agency, which is like FDA in Europe, and it says that ulipristal is safer than many common antihypertensive drugs that we use without any monitoring. Although we are advising to do monthly LFT with ulipristal, and it is only given for 3 months. So it is safe. And just because 1 or 2 patients had liver failure or problem, this is a good drug which should not be just discarded because of those 1 or 2 cases. Pre-treatment with Dynogest followed by IVF in endometriomas helps, and so does post-operative Dynogest or GnRH analogs before IVF may improve pregnancy rates in women with endometriosis. Thank you so much.
Thank you, ma'am. Thank you so much for enlightening us about the pre-treatment modalities for before IVF. Madam, I have a question. When you start them with ulipristal or Dynogest before IVF, when should we stop the treatment before stimulating them? How long should be the pill-free period? Does it have any adverse effect during pregnancy?
It doesn't. You can just stop and then start with the next period.
And we have a question from the audience. Dr. Shivali is asking about role of growth hormone as pre-treatment for poor responders.
Well, I mean, if you look at the general guidelines, they do not recommend growth hormone, although you will find studies for and against. But I did not take growth hormone because that way there are many other treatments which are used for POR, and growth hormone is not just used as pre-treatment. It is actually used, it's more of a co-treatment which people use during IVF cycle. So I thought I would not go into details of growth hormone.
And thank you so much for highlighting that pill-free period is the main point with OCPs and antagonist cycle, madam, because many people have the confusion. They say OC pill pre-treatment decreases the pregnancy rate in antagonist cycle, but the pill-free period should be more than 5 days. Thank you
Yeah.
for.
Thank you.
Yeah, very interesting talk, Dr. Renu. I think you have clarified so many points. And it's interesting to note that, about the comeback of ulipristal. We too used for a few patients. In fact, one of my patients had a FIGO 3 myoma of about 4.2 into 4.5. And she was quite obese and she had undergone a bariatric surgery earlier. So we definitely didn't want to touch her for a myomectomy, whatever. So this lady, we had given, I think we gave her 2 cycles of ulipristal before transferring the embryos. And she, first we transferred 1 embryo, she did not conceive, 1 blast, no conception. Second, 2 embryos, no conception. Then we were wondering whether we should touch this myoma at all. Then the third transfer, all from the same egg collection. So now we transferred 2 embryos the third time, and she has conceived twins, and she did very well. No problem at all. Whole pregnancy went off very well. I mean, do I really owe it to ulipristal, or even without that should have done well? I'm not sure, because you cannot really talk with 1 or 2 kids.
Well,
But
type
is
3,
that-
you cannot say. Type 1 or 2, you're more probably convinced that it will interfere with
Because
implantation.
the size was about 4.5 centimeter, touching the endometrium, no? So anyway, I was quite happy about the happy ending.
I have given mifepristone also to 1 or 2 patients and done IVF. And actually, but I did not mention because I've only given 2 patients, and also they were very small fibroids. But they definitely regressed, and I could do a transfer without doing any surgery.
I think there are a couple of more questions on the chat box.
Do you want me to answer directly or?
No, I mean, I can read, or Dr. Aarti or Dr. Ashmi, you want to read
Yeah,
those?
does pre-treatment with Dynogest affect dose requirement in endometriomas?
No. Does
They want to know about the Dynogest and the dose.
Well, whatever
requirement in
studies I have
endometriomas.
seen, I have not done it myself. There was no difference in dose requirement.
Yeah.
In fact, the dose requirement only increased in earlier some studies which said that prolonged COCs increases the dose, and some studies where there was estradiol pre-treatment, they said the dose increased, but not with Dynogest. It has a different mechanism completely.
The
Yeah, and
only
we
thing
went
I would
through-
add,
we
yeah,
went through
sorry.
different phases for endometrioma. Initially a few years back, it was all removal of the endometrioma, and then we went through the long protocol of suppressing with the GnRH agonist for 2 to 3 cycle, and then do the egg collection. And then we did antagonist protocol without any medication, and now we are trying again Dynogest prior to ART. And I think we are yet to wait and get the results, what exactly is happening.
What I could get from all these, papers when I read that Dynogest seems to work almost as well as GnRH analog. Although I don't think there are any head-to-head trials.
There's another question. What is the maximum duration ulipristal can be given?
Ulipristal, maximum 3 courses. 1 course is 12 weeks. And between the 2 courses, there has to be washout period of 1 month. And what is recommended nowadays is do a baseline LFT and do it every month. Although, like I said, that usually it is a very safe drug. That's what I have read. I mean, my experience is still small, but what I have read that it's very safe drug. These are some idiosyncratic, reactions. Somebody like had a liver failure, but it's otherwise safe. The problem is when you tell people you have to do LFT every month, that actually scares them, because it obviously tells them indirectly that there is some worry, there is some cause of concern. That's why they want to do LFT every month. So maybe in a few years' time, the recommendation would come not to do LFT because there'll be enough data to show that nothing happened to the LFT.
Yeah, but I think it's anyway wiser to do the LFT and tell the patients 1 word, because there were, fatalities.
That's what I'm saying. That's what we are doing, but that actually demotivates half the people.
Yeah, even my patient, when you used ulipristal, we told them, because parents are doctors and all are well educated today. So it's wiser to explain and take a consent.
Yeah,
That's
it's
it.
better to tell them, because tomorrow they find out, they will be after your life.
Yeah,
Even
otherwise
if
there's-
nothing happens to them, they will say you gave us a drug which could be fatal.
So just a comment here, I would say that, there was a question on Dynogest and whether it affects the requirement of dose. So the only thing I have seen is, because I do give Dynogest, and then sometimes you don't get a menstrual period and you have to start the stimulation without the bleed. So they invariably end up in having freeze-all cycles, and they may bleed in between the stimulation cycles. So sometimes you may have to just equate your dose a little bit higher because they're quite suppressed. And they may get a menstrual cycle. So there's just few observations. Again, this is not a hardcore evidence, but because it depends on how long you are given Dynogest for. If
Yeah.
you're just given for 1 or 2 months, it doesn't matter. But if you're
Doesn't
given more than 3 months,
Yeah.
then you may need to little adjust your dose 75 IU higher, or because they're quite suppressed with that.
If she hasn't got a period, if she gets
That's
a period,
right.
then most of the
Yeah,
time
then it's fine. Absolutely.
If she doesn't get a period, it's almost like a PPOS cycle.
That's
That
right.
when you suppress with progesterone initially, then you generally tend to give a little higher dose.
So thank you so much. I think we'll end this session with this, and over to the next session, please. Thank you. Thank you.
Thank
Very
you. Thank
interesting
you.
topic.
Thank you. Thank you, Dr.
Congratulations.
Asha. Thank you, Dr. Aarti. Thank you, Dr. Renu ma'am. So, a wonderful talk. So, moving on to the next topic, I would like to introduce my next chairpersons. Sorry. My next session 2 talk is by Dr. Rajapriya. So, I would like to introduce my chairperson, Dr. Leena Wadhwa. Welcome, Dr. Leena, to this
Yeah,
webinar.
thank you.
Dr. Leena Wadhwa is a professor, OBGY and HOD, ESI Medical College, Alwar. She's a senior IVF consultant and has been certified with setting up her first IVF center of ESI. She's the current treasurer of Indian Fertility Society and has done fellowship with Foxy Ethicon in the field of endoscopy, and has received Dr. Kamini Rao Foxy Oration. She has edited and written a lot of chapters in various books and has publications, nearly 50 research publications in various international and national journals. She's received IFS Achiever Award in 2022 and is now the nodal officer for medical education for the projects of ESI. Welcome, Dr. Leena, to this webinar.
Yeah, thank you, Dr. Puneet.
Our next chairperson is Dr. Neeru Thakral. I'm not sure whether she has joined because her sister was not well. So she has just, she said she'll join, but I'll still introduce her. She is the director of Thakral Hospital and Fertility Center. She's done fellowship from Reproductive Endocrinology and ART Germany. National advisor for Indian Fertility Society 2024-26, current tenure. She's a national coordinator for IFS Young Turks and Secretary General for Gurgaon OBS and Gynae Society. She's been the past secretary for IFS and vice president for Haryana Endoscopy Societies, and holds interest in ART, endocrinology, and endoscopic surgeries. So I would now like Dr. Leena to welcome our next speaker, Dr. Rajapriya. Over to you, Dr. Leena.
Yeah, thank you, Dr. Puneet. Thank you for inviting me for this wonderful webinar on making fertility treatment safe and successful, which is very important need for the hour. So with this, I would like to invite Dr. Rajapriya Ayappan. She is Managing Director, Om Fertility Center, Srinivas Priya Hospital, Perambur. And she's patron of Indian Fertility Society, Tamil Nadu chapter. And she has organized IFS Quiz Come South Zone Coordinator, Secretary of Women's Wing, Perambur IMA, Managing Com Member, Sexual Health Com Member, Foxy. So she has many awards to her credit. So welcome, Dr. Rajapriya. We are waiting to hear from you how to manage mild, moderate, and severe OHSS. Over to you, Dr. Rajapriya.
Yeah, if you stop sharing, I can move ahead. All right. Okay, is my slide visible?
Not
No,
yet.
not yet, not yet.
Yes, oh God. Okay, now how do I do that? Okay. Is it?
Yeah, yes,
Yeah,
yes.
now we can see.
You have to make it full screen, Dr. Rajpriya.
Yeah, I have. I have
Okay,
it.
okay, yeah.
Yeah, so thank you, Dr. Puneet. It's actually a nice theme, making IVF treatment safe. And thank you, Dr. Leena, for introducing me. I guess ovarian hyperstimulation syndrome is like postpartum hemorrhage in OBS and gynae. It just happens to you on a day you're not prepared for it, or you think you have the whole system in control, that such a thing is unlikely to be happening. And I'm glad in the era of anti-protocol and GnRH trigger, where we think we are not seeing much OHSS, Dr. Puneet is reminding us, keep your skills sharpened and be ready. So ovarian hyperstimulation syndrome is one of those complications which are iatrogenic, that is brought in by a clinician to a patient, and the patient at the end of the day has come to become pregnant, not to fall sick. So it's so important for us to be responsible. The pathophysiology is ill understood as to how one person is developing, whereas another possible person doesn't develop it. So we have understood it is a susceptibility of the patient. And we have to be really careful with the trigger, which is a pivotal stimulus to bring about ovarian hyperstimulation. And since we are understanding pathophysiology better, our tools for prevention has also become much better. We have understood that the VEGF expression releases the vasoactive angiogenic substances, makes the vascular permeability increase, thereby a lot of third space fluid accumulation and full-blown OHSS. This leads to multi-organ dysfunction. In a nutshell, it is HCG, vascular endothelial growth factor, permeability, leading to the intravascular compartment movement to the extravascular, thereby hemocoagulation. And these fluid shifts would lead to different types of presentations: hypovolemic shock, poor perfusion leading to multi-organ failure like renal failure, thrombotic episodes, and really megacystic ovaries. When we do the ultrasound, there's massive ascites and body edema, as well as respiratory complications. Now, when should we anticipate OHSS? The early onset occurs within a week of the trigger, which is usually the exogenous HCG administration, whereas the late onset would occur 9 or more days after trigger, and it is mainly related because a pregnancy sets in. Now, when the pregnancy sets in, there is going to be more HCG. So because of the increased HCG, there is going to be a worse form. Actually, the late onset is actually a worse form of OHSS. Now, there was a guideline, almost this is dating to 9-10 years back. That was when the OHSS was a serious complication, and the RCOG had brought in a guideline where there was strict criteria for hospital admission to monitor these women. Those who did not get good pain control, those who were not able to maintain a proper fluid intake due to nausea, where it was important to bring the fluid and electrolyte balance, where there was worsening OHSS and outpatient care, they were not compliant to follow up, or frankly, if they had critical OHSS, it was important. Now, we as outpatient management, in day-to-day practice, we have a caution on the waist measurement. We check if our patients are well hydrated. We check if they're passing urine comfortably. We make sure that there is not much change in weight. And if they have any complaint to say, then we give importance to it. So we have to understand, although the incidence of OHSS is today low, we still have to remember it can be life-threatening. It can be a huge economic burden. And we are moving towards patient-friendly protocols. She has come to have a baby. She is a working woman. She needs to be kept comfortable so that the whole process is a pleasant experience for her. So if we go wrong in it, then there is unnecessary hospitalization for an outpatient protocol treatment. There is unnecessary ICU admission, more economy. As it is, IVF is self-funded by the patient. There is no insurance coverage. Adding on it, if there is going to be a complication, there is a huge economic burden and loss of working days. So what are our options of care when ovarian hyperstimulation comes? It's conservative medical management, particularly symptomatic, reassuring the woman that it is self-limiting, that within a week or two, she will get better. And surgical intervention, that is the other type of intervention. The role of surgery is only in extreme cases when the huge ovary, more than 12-15 centimeters, is going in for a torsion, or if the cyst rupture, or if there is internal rupture, internal hemorrhage due to the cyst rupture. Now, these are the situations where there is a need for surgery. Now, based on the ovarian hyperstimulation syndrome, the form of care is primarily outpatient, but vigilantly making choices as to who gets into the inpatient care and those selective who need an intensive care unit. Now, this is some place where we have to give a lot of importance, because most of the IVF centers today happen to be standalone centers. They open at 9 o'clock and they close at 6 o'clock. So it is important for them to have a tie-up with the center, which is 24/7 open, so that the patient can reach out at any point when they need help. Now, this is a gist of what could the presenting symptoms be. The patient may complain of bloating or abdominal discomfort, but in an ultrasound, the ovary size is usually less than 8 centimeter. But if the ovary size goes up between 8 to 12 centimeter, is more of the moderate OHSS presentation, where the pain, nausea, vomiting becomes more. It's a lot of abdominal presentation. Now, in severe OHSS, the ovary size is more than 12 centimeters. There's a lot of ascites fluid. The patient's urine output starts falling. And when we do the lab parameters, we understand heme concentration, electrolyte imbalance is happening. When it comes to critical OHSS, a multi-organ disturbance happens where there's hydrothorax, tense ascites, oliguria, or even anuria, because so much of ascites gives pressure on the large vessels, and the lab parameters get still worse. The hematocrit is more than 0.55 and the WBC count is more than 25,000, and a picture of ARDS or thromboembolism can set in. And if we are not vigilant, the patient can lose a life. So, as I just talked about mild ovarian hyperstimulation, looking at the gastrointestinal symptoms, a good lot of our PCOD patients are vulnerable. Around 20% may have problems. It is important to keep a check on them at least every 2 to 3 days, and as necessary to do lab profiles. But most of the lab profiles, that is your complete blood counts, your liver function test, or your renal function test, tends to be within the normal acceptable limits. As and how necessary, if the patient has severe pain, unbearable pain, we can introduce analgesics, but avoid NSAIDs because of their renal link and possible problems of renal complication. Ensuring hydration, at least 2 to 3 liters of fluid intake. We have to advise them, avoid physical stress, avoid sexual intercourse, tell them that it can progress to moderate OHSS, and a close vigilant monitoring is necessary. We need to give them a helpline phone number where they can call upon, or a 24/7 emergency service where they can walk in, check their weight and check their parameters. And we have to tell them this is a self-limiting situations, and as and however necessary, medications can be introduced. Now, ultrasound is a key tool where we need to document how much of ascitic fluid is quantified inside the abdominal zone. Anywhere from 5 to 8% can progress from mild to moderate OHSS, and lab parameters start getting abnormal. Now, with the moderate OHSS, if pregnancy sets in, the endogenous HCG can trigger it from moderate to even a severe situation. And monitoring the abdominal girth is very important. So we have to have a standard format of measuring weight and measuring abdominal girth, and making sure that they're having a restricted fluid intake so that the input-output chart is maintained. Again, we cannot be indiscreet in using diuretics just to establish urine output. And there are lots of women who are keen, like if it's a PCOD female, she may have a regular exercise schedule. We have to caution them about it, or they are involving themselves in heavy household work. Again, we have to advise them, and making sure that the lab parameters are not getting very worse. And the key management is just 3 factors: that we have to maintain the intravascular blood volume, make sure the lab parameters are within acceptable limits, and make sure that multi-organ dysfunction or thromboembolism has not set in. Now, when it comes to giving fluids, it is sensible to use isotonic crystalloids, either normal saline or ringer lactate. Unlike before, intravenous albumin is not very promoted, and it doesn't give any additional benefit. Now, hospitalization is something where a patient may resist hospitalization because of the additional expenditure, but the clinician has to be judicious. If it needs hospitalization, they need to insist on hospitalization. And the whole idea is closer degree of intensive monitoring and making sure that the lab parameters may be done daily or more than once daily. And if there is a surgical complication that has set in, like either a torsion or a rupture or a hemorrhage, emergency surgical interventions may be necessary. A hypovolemic picture or hypovolemic shock picture may set in. It is important that any hospital will not do. An OHS's experienced center is better, so they will know how the picture moves from mild, bad to a worse situation. Similarly, a tailored care should be taught to the nurse so she can pick up the signals of severe OHSS. And ICU facility should also be necessary. There's no point in shifting the patient from one form of care to the other. It is better in the initial stages itself to admit them in a hospital which has an ICU care, because end of the day, it's only the moderate OHSS which is going to come into the hospital. Now, the key interventions which are done is paracentesis. So we need to know at what point we are going to decide to tap the ascitic fluid, especially when there is tense ascites or respiratory compromise and breathing difficulty. And if the urine output falls, simply because the pressure is so high that it is affecting renal perfusion. Now, in that kind, instead of doing a blind puncture, it is sensible to use an ultrasound guided puncture. It may be done abdominally or vaginally so that we are protecting the important viscera. At this point, intravenous colloidal therapy may be considered. Now, ultrasound guided is particularly useful to avoid bowel and vessel injury. Now, let's look at how much to be tapped. That is, no standard guideline is there. It is unclear, but the multidisciplinary ICU team can shed light as it is safe, that the patient is relieved of the symptoms, the tension in the ascites is coming down, the urine output is better, and thereby take a call, but not more than 4 liters in one sitting. What about pregnancy? Now, when the woman gets pregnant, she is going to move into an aggressive presentation of OHSS, and she is going to take longer than the usual 10 to 14 days. And that's a great testing time for the clinician and the patient. On one side, you're excited that she's pregnant, but on the other side, you know that this course is going to go downhill. And mind you, if we don't strictly follow the transfer of embryos as a single or double embryo, we're going to be in soup if multiple embryos has been put in, which is against the ART law. Now, severe OHSS picture can range anywhere from 0.5 to 2% incidence, and all the lab parameters go haywire. Creatinine increases, there's hyponatremia, there's hyperkalemia, the liver enzymes start increasing, the various systems, the cardiovascular system, the respiratory system, the renal system, the abdominal GIT, everything is going berserk, and it is important to plan proper care. So we have to give relief if critical OHSS occurs from pleural effusion. So you need to have a multidisciplinary ICU critical consultant who knows how to take care of the various complications which are likely to set in, like arrhythmia might come in, thromboembolism can wreak havoc, pulmonary complications can happen, a massive hydrothorax can happen, ARDS can happen. And what about sepsis? So instead of allowing these complications to happen, it is important to try and prevent or manage efficiently if they are happening to set in. So volume expanders, albumin is something which has been used because of its low molecular weight, and it increases the plasma oncotic pressure. Blood-derived product is albumin. We have to have a discretion not to use it unnecessarily. Albumin can give rise to allergic reactions, anaphylaxis, and the transmission of viral disease. However, there is mixed review that albumin was always thought as a very useful intervention, but there are some RCTs which say that it is not mandatory to use it either. With respect to diuretics, when there is worsening hypovolemia and the blood pressure, everything is not maintained well, it is incorrect to use diuretics without discretion. So the multidisciplinary team would decide how often to check the fluid and electrolyte balance. They would act upon the rising weight and the abdominal circumference. They would ensure that if she is getting pregnant by the rising serum beta-HCG levels, as to have a continuous discussion whether the patient is able to cope up, understand the risks, and they are willing to continue the pregnancy, because there are some patients where if the life-threatening critical OHSS sets in, we may have to take very difficult decisions. The same dream which she wanted, a baby, is going to act like a devil in her and take her own life. Certain very tricky counseling decisions are important. So we need to have counseling and consent in place. We may have to involve the partner to give him a day-to-day update as to what is happening and how far they are willing to go with the risk. And we should not hesitate to offer termination of pregnancy if it appears crucial in bringing her recovery. Central venous pressure monitoring may be necessary, chest radiograph and echocardiogram. And especially when a pregnancy happens, there is a lot of resistance to taking a chest radiograph. Appropriate prophylaxis based on the score, on her age, on her weight, on the comorbidity factors, low molecular weight heparin or fractionated heparin may be used, and even stockings during inpatient care. And with severe complications, accordingly, the treatment will be tailored. And this is a topic by itself, which is best dealt by a critical consultant. But our goal is to correct fluid and electrolyte imbalance, to give relief from ascites and hydrothorax, to prevent thromboembolic disasters, to monitor sepsis by using broad spectrum empirical antibiotics, especially when there is constant ascitic tapping or urinary catheter monitoring. The sources of sepsis can be from different routes. So it is important for us to be sure. And as the patient starts recovering from the self-limiting condition, there is this beautiful phase of resolution. When the third space fluid begins to re-enter the intravascular space, things get better, hemoconcentration reverses, urine output starts flowing, all the lab parameters starts getting better, the ultrasound parameters of ovarian size reduction, ascites reduction, patient clinically improving is all good news. And finally, the patient would have crossed a huge barrier in her whole outcome. And in certain women who have become pregnant, there are two opinions that an OHSS pregnancy is well salvaged. On the other hand, OHSS pregnancy may not be a very pleasant pregnancy with a miscarriage and possible future complications of gestational diabetes or pregnancy-induced hypertension. Mortality is purely dependent upon the unit taking care, upon the vigilance, about whether all the necessary related parameters were taken care of well, as well as the individual susceptibility. And I would like to conclude my presentation saying, do no harm should be our principle in modern day with patient-friendly protocols. The key thing is to be able to run an OHSS free clinic, and that's what as clinicians we all endeavor for. And if such an event happens, we should not allow the mild OHSS to progress and be vigilant. So thanks for this opportunity and hope we don't face OHSS in our practice.
Yeah, thank you, Dr. Rajapriya, for a very nice presentation and very elaborate. You have explained everything. Just a comment to add on. When a patient, if she goes in moderate or severe OHSS, one needs to keep in mind the risk of ovarian torsion also.
Yeah. That's one of the surgical complications, right?
Yeah. So we can take up the questions now, if there are any in the chat box.
Can I ask something?
Please, madam.
Dr. Rajapriya, what is your standard prescription where you think patient is at very high risk of going into OHSS?
Ma'am, the minute we are seeing certain patients, especially the two key things, no, when she gives the abdominal discomfort symptoms, the ultrasound is showing a larger volume of ovarian fluid, we have to immediately open up the discussion and start counseling. Look, you're going in for OHSS, and encouraging her to have a good fluid intake, watching herself. And as a prescription, cabergoline is something I tend to give 0.5 milligram daily. And I also encourage them to take caffeine. And there are these Dolopar tablets, paracetamol with caffeine, which I tend to give to those women who have a lot of pain, just for a couple of days till she learns to cope up. There are situations where I give injection antagonist for a period of 5 days till the ovaries start shrinking and till the estriol levels start dropping. There are people, some of my friends whom I know, who use letrozole as well to make the estradiol levels fall, but there is no enough evidence to suggest that on a platform like this. I would love to hear in your experience what you would use as an agent.
I used to use cabergoline, but now I'm very happy with letrozole.
Letrozole. Okay. So I do hear some of my friends. So you use it for how long? For 10 days?
No,
2.5?
normally, like after pickup, if I feel somebody it has a very high risk, then 5 days.
5
5
days.
Yeah,
milligrams.
5 to
Ma'am, can I
7
add
days. We
something?
have
Can I
also
add something?
used.
Can I
Yes.
add
Yeah,
something,
yeah.
ma'am?
Dr.
Yeah,
Nisha?
so ma'am, the moment we suspect that there is a OHSS, we start the patient on cabergoline, even if we have not given the trigger. From the day of, suspecting that she's blending
Yes.
into OHSS, I'm starting cabergoline. Now, the
0.5.
moment, yeah,
Before the
0.5,
trigger.
vaginally. Even
before-
before trigger, yes, ma'am, even before trigger. So that leads to less fluid accumulation in the POD and pouch of, you don't have too much of free fluid also. The day we do the pickup, we retrieve, and then that day we give 1 or 2 wax of Hess, and on top of that we give 2 Citrolix, and then we put the patient on cabergoline along with letrozole. Letrozole is a wonderful drug specifically for prevention of OHSS in such cases. 2.5 milligram BD for 5 days. There is no need for any Citrolix. There is no need for anything else.
Works. It
But
just brings the
Pardon, ma'am?
estradiol level very quickly down.
Yes,
Yes,
And
ma'am.
in fact, we
Yes,
don't
ma'am.
use anything, no Hess, no,
Yes, nothing is needed.
So it's nothing
Yeah.
now.
Ma'am, Hess we usually give on the day of pickup only, while after,
But
like,
now they say there is no
Yeah,
role.
there is
no
no
role,
evidence now to
Albumin,
support the
even
calcium.
saline, no role, people say now.
yes, ma'am.
So
Letrozole is wonderful.
We've stopped giving everything, all these things.
Yes.
So cabergoline and letrozole is something
Yes.
which are
In
easy
fact,
for the patient to consume.
the guidelines mention cabergoline,
Cabergoline.
but nobody mentions letrozole as yet.
Yeah,
Probably
we give
take-
cabergoline along with letrozole.
And few years back, Asharaf here, few years back, one of my patients, it was an agonist cycle already. And no, it was not very sure. I mean, she was also a case of chocolate cyst. So those days we did not have AMH. This should be about 12, 15 years back. We had given her 300 units stimulation for about 5 to 6 days. And then we saw she was standing with almost 30 oocytes on either side. And E2 was 9,000. And your agonist cycle, so your hands are tied already. And somewhere I had read, and we gave her a dose of antagonist. And after antagonist, called her the next day, the E2 had dropped down from 9,000 to 900. But now I saw about 4 to 5 follicles of 1.6 on either side. So we gave her 1 more day of antagonist and gave her a mild stimulation like 150. And then we gave her a trigger, did a collection. We got about 8 to 9 oocytes, and we had 6 embryos which were vitrified. Those days vitrification was not so strong. We transferred 2 embryos fresh, and other embryos were vitrified because it's the early days of vitrification. And we were all waiting for the OHSS to happen. Nothing happened. Pregnancy test came positive. She did very well. Continued pregnancy, no problems at all. We had done it for about 4 patients.
That's a very brave thing to do now, ma'am. Face
Yeah, in today's era, nobody will
From
even
9,000,
try
the
this.
E2 came to, from 9,000, the E2 came to 900. So it's a cycle is gone. I will not get any oocytes. But we got about 6 to 8 oocytes and enough embryos. And this was 4 patients, but I think we did not publish it that time.
Yeah.
Thank
So
you
one more
for
question,
sharing your
any role of
experience.
heparin?
Yeah, Dr. Leena, there are some questions in the chat box also.
Yeah,
from
there is
delegates.
one question on role of low molecular heparin in OHSS patients.
No, that very clearly only if there is an indication of the risk score is high, we give. It is not standard protocol. Of course, in the moderate situation, when there is a need, the risk score is high, then thromboprophylaxis is started. Low molecular weight heparin, depending upon the body weight of the individual, has to be given for a period till they bail themselves out. And with respect to letrozole, I think we were pretty clear that 2.5 mg twice for a period of at least 5 days, and cabergoline 0.5 mg for a period of at least 5 days till we are able to tide over the critical phase. And
yeah, I think all are covered now.
Yeah.
Thank you, Dr. Rajapriya. So
So-
we can conclude this session.
Just a
Yes, Dr.
comment.
Puneet.
Just a comment.
Yeah,
I think
yeah.
Dr. Rajapriya in the beginning pointed out a very important point that because we all fertility centers are daycare centers, and as per the ART law, we need to have a tie-ups with multi-speciality or care providers with ICU facilities. So I think it's very important that we reiterate that fact that we have those collaborations to make it safe for our patients, just in case if it happens. We're doing everything to prevent it, but I think that's important mandatory thing from ART law point of view as well. So we need to have those collaborations.
Yeah, very important point.
Is it
Well
in the
taken.
law?
Yes, it is. It is in the law. Yeah.
A lovely talk, Rajapriya. Once again, just two more sentences. Last few years, I think almost 10 years, we've not seen OHSs in our center. And recently, about 5 months back, one of the patients was operated twice for chocolate cyst. Young girl, her initial AMH was supposed to be 4, and another center we got 6. The third center gave 8. And she had egg collection first time with the antagonist protocol, 3 oocytes. So the second time we went in for agonist protocol, 8 oocytes. And after 4 days, she came with pain and we saw some fluid in her, mild OHSs. And this was a patient who was operated for chocolate cyst. So even these patients, chocolate cyst, sometimes they have a combination of PCOS.
Yes,
so we have to be
yes.
careful.
Yeah.
Yes,
So the
very
AMH of 8
important.
maybe was correct, because AMH is different from place to place sometimes.
The susceptibility is something we have to keep on
Yes.
caution and track the POD
So
fluid.
keep your eyes open all the time.
It's like think ectopic, no? We have to think OHSs. So thank you so much for the opportunity. It was lovely sharing the interaction and learning from you as well.
Yeah, thank you, madam. Thank you, Dr.
I
Puneet.
enjoyed your talk. Yeah.
Yeah.
Thank you so much for lovely discussion. Moving on, we move to our next session, which is a debate. And I would like to introduce my judges. 1 second. Dr. Nisha, can I just share the screen
Yes,
for a
yes, yes.
sec?
I've
Yeah,
stopped,
just,
I've stopped.
yeah, just thank you. Thank you. I would like to welcome, I think I saw Dr. Abha ma'am. Abha ma'am, have you joined? Are you there? I think I saw. So I would like to welcome our judge for the next session, which is a debate. Our judge is Professor Abha Majumdar. She needs no introduction. She's an emeritus consultant and director and head Center of IVF and Human Reproduction, Shri Gangaram Hospital, New Delhi. She's also the mentor of our SIG Reproductive Endocrinology and has been our guide in this kind of SIG. She's got President's Medal and 7 gold medals as medical graduate. She's been responsible for the birth of the first IVF baby of North India. She's been awarded Abdul Kalam Gold Medal Award, Rashtriya Gaurav Gold Medal Award, Rajiv Gandhi Gold Medal Award, and she's a brilliant teacher, Distinguished Teacher of Excellence Award. She's been the IVF Champion of Year 2019, Best Integrated National Teacher Award. Too many awards to her credit. She's got the Lifetime Achievement Award in Obs and Gynae by Hippocrates Foundation 2014. She's involved in teaching a lot and is post-director for postdoctoral fellowship in reproductive medicine. She's member editorial board of IVF Worldwide and has numerous publications and book chapters to her credit. Our next judge is Professor Shweta Mittal Gupta. She's the current Secretary General of Indian Fertility Society and has been the past treasurer IFS. She was also the past convener of SIG, Reproductive Endocrinology, and has been the recipient of Economic Times Award for inspiring Obs and Gynae. She is currently co-director and unit head of Center of IVF and Human Reproduction, Gangaram Hospital. So I would welcome both Dr. Abha Majumdar ma'am and Dr. Shweta Mittal. I would now like to introduce our debate person. So the debate is on personalization of ovarian stimulation. Again, the purpose of this talk is to see whether we can make it more safe by personalization. And for that, in favor, Dr. Nisha Bhatnagar will be speaking, and against Dr. Kokila Desai. So I would like to introduce Dr. Nisha Bhatnagar. She's a medical director at Avia Fertility and IVF Center, and also medical director at Infinite Egg Freezing Center. She's a faculty at ICEAT Academy and head Infertility Committee, DGF West. She's actively involved in education and training. Her area of specialization is natural cycle IVF and minimal stimulation IVF and poor ovarian response. She's got memberships of various organizations and has presented papers in various meetings and conferences, and has book chapters and publications to her credit. Welcome, Dr. Nisha. Dr. Kokila is practicing in Surat as in Morpheus Shivam International IVF Center. She did her graduation and post-graduation from Vadodara and has taken advanced laparoscopy training in reproductive endocrinology also from Germany. She has received Sulu Rudra Sinha Award and presented papers and invited as faculty in many different conferences. So welcome Dr. Nisha and Dr. Kokila for continuing this debate forward. I will stop sharing and ask Dr. Nisha to let me just see Dr. Abha Majumdar ma'am is there. Just can you give me 1 second?
Yes, yes, I have not shared.
Okay, just give me 1 second.
My time should start afterwards, huh, Dr. Puneet?
Let me just make sure that she's there.
Dr. Abha
I
is
can
here.
see her, but
See
let
her
me.
name.
I can see her name. Yeah, she's joined, but let me just make sure she's switched on her. She's unmuted. Just 1 second.
Rajapri, are you there? I have a question for you regarding OHSS, secondary OHSS.
Yeah, Arti.
Is there a role for letrozole and all in secondary OHSS?
In mild and moderate, we tend to use letrozole. No, that is the minute we are looking at an OHSS picture, as we had Dr. Nisha and Dr. Renu sharing. The minute we are suspecting, we are initiating it in the mild itself to prevent progression.
One of my friend had a secondary OHSS, that is 4 days, it was an IUI cycle.
We are talking about secondary OHSS.
Secondary OHSS.
Secondary OHSS, I don't have much experience, or we didn't talk much about secondary OHSS. I think we have to be very defensive, because when a pregnancy happens, we do tend to give a weekly HCG. We tend to be a little liberal with HCG as a luteal support. So I think it would just be whatever I said, no, managing fluid and electrolyte imbalance and making sure thromboprophylaxis is right, and telling her that she is going through a risk herself. I'm sure letrozole cannot be given in that kind of situation, and there is no literature also to talk about secondary OHSS. Any comments about others using any particular medication?
But maybe you will not give letrozole, but maybe at the same point of time, you will not support with HCG also.
Yes, avoid HCG.
Just give normal progesterone. So that would be better.
Secondary OHSS, you just have to tide over with the supportive care.
Okay, so I think we can start our next session. Dr. Abha ma'am is all very much in. So I'll hand over to Dr. Nisha and then to Dr. Kokila, and then subsequently to Abha ma'am to give her final decision and comments. Dr. Nisha, it's over to you first.
Thank you. Thank you so much for giving me this opportunity. And first of all, my sincere thanks to Dr. Puneet and this SIG for giving me this opportunity. I would like to start my time now, Dr. Puneet. So my topic is individualization of controlled ovarian stimulation. Is it a need or a hype? So I am a person who believes in individualization to the core. I believe that individualization is the need, and it is the only way we can treat infertility. So I think, just a second, I don't know why it is not moving. Yeah. Can you see my screen changing, right?
You can put it on screen, this
Full
thing.
screen?
Right,
Yeah.
full screen, yeah.
I don't know why it's not coming there.
Down.
Down there.
Yes, ma'am. Sorry. Yeah.
Thank you.
So all of you must be familiar with this quote from William Osler, which says that medicine is a science of uncertainty and an art of probability. This quote emphasizes the complexity and variability of medicine, specifically in our field, where individual differences can greatly influence the outcome. We know not only no two human beings are same, even the fingerprints are not same. Even not only that, when we see a couple, there are two different people. We are investigating two different people and we are giving a combined result. Even if they plan to, in future, if they have 4 children, those 4 children are also not going to be same. So how can we give one fixed treatment to all? So I'll be talking about little bit about introduction, why individualization is needed, what is individualization, how it can be done, where is the predicted high response, low response, and then we will conclude. So most medical treatments designed for average patient with a one size fits all approach. You know, you have fever, you give crocin, you give this antibiotic, you give that antibiotic. It might be successful for many specialties. There are certain protocols, SOPs, but in infertility, specifically in our branch, this one size fits all doesn't apply. There are personalized medicine which is needed in our field. These are tailored approach to the specific need and considers inter-individual differences. For example, you need to understand that what is the reason of this patient, what is the reason of infertility. If there is a patient with tubal factor or a mild factor, you are not going to stimulate her with 225 international unit of gonadotropin. You just need to overcome. If there is a mild male factor, you can go for a mild stimulation as well. Now, another thing which is unique to our field is the psychological stress and the emotional well-being. These patients, they have a lot of burden. Some of them are more stressed, some of them are less stressed. Some of them have more, sort of backup and official office pressures, work pressures, society pressures, their house pressures, and they are not emotionally stable. Their support system may be there, may not be there. Their financial stability is another factor which we need to consider. So considering all these factors, I think individualization is the key. We have to address the patient as an individual and then treat it. What are the objectives of this individualization? This is for maximizing the success. As we already discussed, eliminating OHSS, minimizing the cycle cancellation, reducing the cost, reducing the dropping out, and improving the patient compliance. So it has evolved over the period of time. In recent years, we have seen that there's more talk about individualization of controlled ovarian stimulation. It is basically very good for oocyte retrieval and couples prognosis. How we do it? We do it on basis of age, BMI. We do it on basis of ovarian reserve. We classify them according to the different Poseidon groups. We classify them according to the reason of infertility. For example, if a patient coming to me who's 39 years of age and has very low ovarian reserve, there is no point in giving her too much hormones or something. Or if it is premature ovarian failure, no need of trying for her for a normal cycle. You can directly go to her what is needed for her. So what is to be done? How you can individualize? There are so much to choose from. You can choose the protocol, whether it is agonist or antagonist. You have to choose the type of gonadotropin, whether it is a HMG or a recombinant, or you are going to do recombinant FSH plus recombinant LH. You have to decide on the starting dose, whether it is going to be 150, 75, 187.5, 225. What is the trigger you are going to use? Is it going to be the dual trigger, a single trigger, or only deca trigger, agonist trigger? What are the adjuvant therapies? Is there any need of growth hormone? Is there any need of metformin? Is there need for anything else? You are going to do a fresh transfer, or you are going to go freeze all? You are going to do day 3, day 5? All these things needs to be decided, and then you can individualize. You have to see the patient as a couple, as an individual, and then decide what kind of all these things you are going to do for that patient. Now, there is another talk coming about nowadays, role of genetics. There is FSH-LH polymorphism. You see that, some patients, everything else is normal. You see very beautiful ovaries. FSH is also normal. When you stimulate, the patient doesn't respond. There is some kind of FSH-LH polymorphism. There is blockage. Patient is not responding to the injections you are giving. So to overcome all these things, you have to classify the patient as poor, normal, hyper responders. And then there are various models given. I will not go into details of these models. The most commonly used is La Marca et al. In 2013, where they gave the basis of age and AFC. They gave the starting dose which needs to be given to the patient. Now, I'll just give you an example of individualized controlled ovarian stimulation using AMH versus conventional controlled ovarian stimulation. See here, this was done by Leo RBF Nakano, and was published in ASRM 2013. There they said that individualized controlled ovarian stimulation on the basis of AMH only, where they saw in case of high responders, where they predicted they are going to give a high response. When they did individualized and controlled ovarian stimulation, the observed excessive response was only in 14.3% of patients. The oocyte retrieved number was similar. The OHSS percentage was very low, and the pregnancy rate was similar, 56 to 57. There is no statistical difference. So there is another example of individualized controlled ovarian stimulation using AMH versus conventional controlled ovarian stimulation. In these cases, they predicted that there is going to be a poor responder, and they individualized the stimulation protocol for that particular group. There they saw that the expected poor response, again, the percentage was less. The oocyte retrieved number was similar, a little higher in case of individualized controlled ovarian stimulation. The cancellation cycle rate was much lower, and the pregnancy rates were higher. So individualized controlled stimulation, again, I need to put a stress here that it is a need and not a hype. This is just a rough example how you can go, whether there is a PCOS diagnosis, no PCOS diagnosis, age is there, then age is less. You start with low dose when there is in case of patient predicted to have PCOS, you start with low dose. If age is high, there is no PCOS, you start with higher dose. Then you put the AMH in line and you can adjust the dose accordingly. This is just an example to make you understand that how we can do individualization. In fact, I think nowadays individualization is controlled over stimulation is synonymous to treatment of infertility, to the extent that chocolate means Cadbury. Now, this is another article where by Confronti, it was published in Biochemical Clinical Pregnancy in 2017. They say that specific genetic tests such as SCR680 variant of FSH receptor might lead to pharmacogenic approach to controlled ovarian stimulation. You need to find out that if there is some kind of genetic variation, why the patient is not responding. Another article, a very famous one, published in 2011. They give many, this was the first one done by Bosch in controlled ovarian in individualized controlled ovarian stimulation. They said that IVF approaches has significantly improved, but still there is no fixed regime. People have tried mild stimulation, moderate stimulation, but there is no one fixed protocol which we can say that this is going to give you result. So they proposed that the treatment should be adopted for individual patient through ICOS, and together with the further development of objective biomarkers, it will be an important first step towards implementing personalized medicine in reproductive science. So to conclude, it is now very clear that one size fits all approach is not recommended. Individualization of gonadotropin starting dose is very important. ICOS is based on correct prediction of ovarian response, especially the extremes, poor, hyper, by most sensitive markers like age, AFC, and AMH. I will believe that age is the most important criteria. Then reduction in it leads to reduction in inappropriate ovarian response. It leads to reduction in withdrawal from treatment. It leads to reduction in cycles with poor prospects for success, less cycle cancellation, less OHSS, and it leads to improvement in overall cost effectiveness. To summarize, there are diverse patient profiles. Every patient undergoing IVF is unique, and there cannot be a one-size-fits-all approach. You have to optimize the outcome. You have to optimize the number of eggs retrieved, improve embryo quality, and ultimately increase the chance of a successful pregnancy. You have to minimize the risk. Nowadays, you cannot afford to have a OHSS. You have to decrease the cost, and the treatment has to be patient-centric, keeping the specific needs of the patient in mind. For example, emotional, psychological, financial. Just to give an example, again, patient with a mild male factor or a tubal factor, young age patient with good ovarian reserve can go for a natural cycle. She does not need to take too many injections, have 20 blastocysts in your lab, those kept frozen for long. Now, the real question is it a real or a hype? So what do we mean by individualization? So when we say that we are going to start the gonadotropin dose depending upon the age or AMH, is that individualization? Maybe yes. When we say that we are going to start the dose on the basis of the BMI and weight, is that individualization? Maybe yes again. But what individualization exactly means is that when a couple comes to you, and especially it is important in case of previous multiple failures, you have to analyze the whole cycle. You need to see what was done for that patient previously, what did not work for that patient. There has to be a complete analysis of what treatment was given, what dose was given, what number of days was stimulation lasted, how many eggs, how many M2, what was the fort, what was the foci, was it belonging to expected poor ovarian response, was it belonging to unexpected poor ovarian response. So you need to classify the patient and then tailor-made approach for her for the next cycle. So to me, this means that whenever you have a failure, whenever you have a patient who has failed, there is nothing which you just simply say that, okay, this is the treatment for this patient, you will do everything. No, you have to analyze that patient. You need to see whether she needs a hysteroscopy or not. Hysteroscopy for all? No. Hysteroscopy only if needed. ERA for all? No. ERA only if needed. PGT for all? No. Whatever is needed for that patient, that needs to be prescribed, and from there on, the patient needs to go on. And it is very, very important that standardization should be done in others, like, all the centers, all the nearby centers. We should have a standard format, like, sort of grading system for blastocyst and everything that needs to be implemented, so that at least failure from one place, you can analyze that what was done and what can be done to improve. How it can be achieved? Again, it's a time consuming process. You need to sit down, you need to analyze the previous record, you need to tailor make the protocol for patient, and again, keep reassessing the patient in between. Now, Albert Einstein also said that insanity is doing the same thing over and over and expecting a different result. We cannot have a different result if we are doing the same thing again and again. That's it from my side. Thank you.
Very nice. Well done.
Thank you. Best of luck, Dr. Kokila.
Yeah. So shall I start?
Yes, I'm stopping the share. Sorry,
Yeah.
Stop the share.
Okay. Sorry. I am visible?
Yes, you are. Your slide is not visible.
Slides are not visible yet.
Now?
No, not yet. You sharing through that share button, Dr. Kokila?
Yeah.
Share button at button at the bottom.
Sorry.
Meanwhile, I'll welcome Dr. Shweta Mittal. I think she's joined as well.
Yeah. I heard the first presentation of Dr. Nisha.
Thank you. Dr. Kokila, you
Now
want
I'm
to share
waiting for
this?
Dr. Kokila
No, I'm
to
just.
speak
I'm not
on
able to
one
share.
size fits all.
I'm not able to share here.
Have you been made the co-host?
Yeah. Dr. Kokila is the co-host. Do you want to share the slides to me? Do you want me to? If there's any problem, you can just send it to me by WhatsApp. Karan, can you just check on with Dr. Kokila?
Why I'm not able to share? I think there is something wrong with the Zoom part.
So you are the co-host, Dr. Kokila. Do you want to share the slides to me as well? Meanwhile, I'll try through here.
Yes, ma'am. I can share.
Can you see the share icon at the bottom or no?
I cannot see. More is seen audio, video, then more and leave.
No,
More
audio,
is
video,
showing.
and then go on.
Ma'am,
Rest
Dr.
of the
Kokila,
panel.
ma'am, at the bottom where you are
Yes.
seeing your audio, video, participant, chat.
And can you see now?
No.
Ma'am, where there is a chat button, inside of the chat button, there is a green button with share.
हाँ, chat button के अंदर share लिखा, मैम. I'm sharing it. Share the screen option. One participant can share at a time. It's coming.
So
Dr. Nisha, have you stopped sharing yours?
Multiple participant can share simultaneously. Shall I stick on that?
Try that.
Yeah, so you just, I think you're clicking on that the inverted V. You just click on that green button. You will straight away go to share. Just click on that green button, arrow going up.
Yes. share screen option. Should
Yeah.
alter.
Yeah, click that and see.
Is it now available? I don't know what's happening.
No, no. Do you want to just, now I think we can see something happening.
Okay.
Yeah. Yes, we can see now. If you can put it to full screen mode, that will be good.
Light share icon at the bottom of your slides. Or maybe on the top if it is Windows.
No, I
Is it
think
now?
it's at the bottom. Yeah, it's at the bottom. Yeah, perfect. Thank you. Yeah. Please
Okay.
proceed.
My time starts now. I think so. So personalization of ovarian stimulation in IVF, either it's a hyper need. Dr. Enu ma'am has said so many things about the pre-treatment in a different patients. So here my main question is whether a personalization of ovarian stimulation is a necessity or simple a hype. The IVF technology is evolving and the concept of personalized treatment is heavily marketed. Purpose of the debate is to analyze whether it's a personalization is a true need or it's a marketing strategy. When the ISHRA guidelines says so many ovarian stimulation protocols are available for low responder, normal responder, high responder, then again there is a subdivision of low responders. And if you consider low responder, there are subdivision of PCO and low AMH cases. In PCO, there are so many phenotypes available. And even in a low AMH cases, there is a persistent 4 group available and different protocols are available online as well as in a literature for different group. I think it's very difficult to say that it's a hype. But still, because I have been given a topic, I would like to justify it as far as possible. So, the standard IVF protocols, it's a traditional approach. One size fit for all stimulation protocol have been widely used with success. We all have practiced a long protocol for a long era of time from 2010, 2015, like that. And then when the antagonist emerged, there was lots of debate between long and short. That is the antagonist and agonist protocol. And with the use of long protocol as well as with the use of antagonist protocol, many women has achieved pregnancy using standard stimulation protocol without any complications. It is very simple and effective. Traditional methods are cost effective and less complex. So the rise of personalized ovarian stimulation, I would like to discuss in these 4 points. One thing is personalization involves tailoring stimulation protocol based on individual marker like AMH, AFC, age, pre-existing pathology. Due to lack of standard guidelines, there are no universal accepted definition of personalized protocol. Then there are people claim to improve the success rate by adjusting to the patient specific need, but study shows minimal difference in outcome compared to the standard protocol. So it creates an impression of a more tailored IVF experience, which may increase the cost and complexity. So here is the age and pathology. When I searching for the literature, I saw that this study was published in 2015. There they have discussed the short versus long gonadotropin releasing hormone analog suppression protocol in IVF cycles. 5,662 IVF patients has been taken from 2010 to 2013 and they were retrospectively identified. The cycles were divided into 2 groups, long and short. And again, they were divided according to the age, less than 31, 31 to 35, 36 to 40, and more than 40. The duration of stimulation, total dose of gonadotropin, implantation rate, and pregnancy rate were compared. And the author has concluded that regardless of the patient age, the long protocol was superior to the short protocol in terms of number of retrieved oocyte as well as implantation and pregnancy rate. Another article, comparison of different stimulation protocol used in IVF, published in 2015 in again Pub Medical Journal. The review summarized the available evidence from the previously published literature regarding the efficacy of different IVF protocol. They had used GnRH agonist protocol compared with antagonist and minimal stimulation. And a close assessment of the cost-benefit factor demonstrated that the agonist long protocol is better than other IVF stimulation protocol. And the main goal of control over hyperstimulation is to obtain a greater number of mature follicles and suppressing the premature LH surge. If that is achieved with the single agonist protocol, why to search for another personalized protocol? Then they says that previously existing disease may affect your stimulation protocol. So here is one of the study which has been published in a Frontier Endocrinology 2021 in a Pub Medical Center. The ultra long protocol. has been used and compared with the long protocol in a patient to see whether it improves the outcome in a woman with adenomyosis. It was a retrospective cohort study, and however, they found that the pregnancy outcome showed no difference between the two protocols in a woman with focal adenomyosis. So, in spite of using different protocol, if there is no benefit, why to change the protocol? Second thing is most important is lack of standardization, standardized guideline, and lack of substantial evidence. So many studies shows no significant difference in a live birth rate between the personalized and standard protocol. Meta-analysis often reveals comparable result. So why to go for a different personalized strategy in a different patients? And if you see for the personalized protocol, there are so many protocols are available: long protocol, ultra long protocol, ultra short, antagonists, mini stimulations, progesterone, PPOS. If you go in a depth of that antagonist, there will be a CC with a gonadotropin, there will be letrose with a gonadotropin. So there are so many different protocols are available, which can confuse the newcomers as well as to us also sometimes. And so do you think the personalization of and using different protocol are required in the patients? Coming to the PPOs, if you analyze one stimulation protocol like progesterone prime ovarian stimulation. So when I searched literature, I found different types of progestin has been used. Progestin has been used by one of the author, another author has used Dynogest, third person has used oral medroxyprogesterone acetate. So basically, which progesterone to be used has not been standardized. What dose should be used, when to start, when to stop. All these are still not guidelines and not standardized. So do you think should we go for a different type of this PPOS type of stimulations in the such patients? Another thing is when I was searching literature, I found an article, Language Matters Rename. It was published in 2024. Again, the name, the progesterone prime ovarian stimulation itself is a misnomer. They says that progesterone prime ovarian stimulation is a misnomer because progesterone has no role in a priming of the ovaries for ovarian stimulation. And so they says that it should be labeled as a progestin protocol. So when even the name of the protocol has not been standardized, do you think we should use these different types of protocol in a different patient? Third thing is my opponent said that claim to improve the success rate by studying so minimal differences outcome has been compared to the standard protocol. So here are the studies. This was a study published in 2020 August. Mild versus conventional ovarian stimulation for the IVF has been used in a poor responder, a systemic review and meta-analysis. And the author has concluded that our review indicated the mild ovarian stimulation of IVF could be as effective as conventional high-dose stimulation for poor responder with a moderate to high-quality evidence on pregnancy outcome. Then why you want to categorize the patients in a 4 procedure criteria? Then another study of comparison of control ovarian stimulation protocol for IVF, meta-analysis published in a Chinese journal, October 2020. Objective was the purpose of the present meta-analysis to compare the effectiveness of different type of gonadotropin protocol. Even in a long protocol, there are 3 different types of protocol: long-acting follicular, long-acting luteal, and long-acting short-acting luteals, and then antagonists. So there is so much confusion about the different protocols, and they have done the study to find out whether they are effective or giving a benefit to the patient or not. And the author has concluded that GnRH along a protocol were found to have a potential benefit over any other protocol which has been studied in this study. Then another study published in 2021 in a Springer, comparison of long-acting agonist follicular protocol with a antagonist protocol in a woman undergoing IVF, a systemic review and meta-analysis. And the author concluded that long-acting GnRH agonist follicular protocol was also beneficial in improving the live birth rate, clinical pregnancy rate, and implantation rate, whereas the incidence of OHSS was significantly lower in a woman undergoing antagonist. So like, why can't we keep only 2 protocol, long and short? That's it. Then there is no clear impact on the success rate. Meta-analysis show that personalized stimulation does not necessarily improve the cumulative pregnancy rate. Standard protocol often provides similar outcome, and personalization does not automatically improve the success for the patient. So why should we go for that? The most important part again is that it increases the cost. The personalization protocols requires more expensive diagnostic and medications. This aids a financial burden without significant improved outcome. As you know, the simply making tea in the lari, which will cost you very less. But when this tea travels through a 5-star hotel with added tea adjuvants and personalized touch, it becomes very expensive. So same way, if you are using a personalized protocol for ovarian stimulation, it's going to become expensive. Then complexity without necessity. Adjustments are often minor and may not drastically improve the outcome. Many centers are running satellite centers, and so it's very difficult to control those centers with a personalized touch. And I don't say that we should use only long protocol, but we should standardize single protocol which should be remain same for all the patients. Frequent monitoring can be delayed treatment cycles, adding unnecessary stress. Standard protocol often yields similar success with a less complexity. And when you are using a personalized protocol, training of the staff, training of assistant doctor is required. And it becomes a project like managing a complex project. And if you are not able to give a personalized touch to the project, sometimes it adds disaster. So in spite of using a standard protocol, if you are adding some complex protocol or some complex things which can make a disaster for your centers, because every patient has to be individualized, then staff may not be knowing which protocol to be used in which patients. Your assistant doctor may not know which protocol to be used in which patients, and they may make a disaster. So it is I would say that it's a marketing strategy. The term personalized appeals to be a patient seeking an individualized approach. However, personalization is often more of a branding tool than a clinical necessity. It can provide psychological comfort, but this does not always translate to improve the outcome. It has a placebo effect. Basically, the patient feels more reassured because you have tailor-made their program, so they think that they are going to get a good success. Psychological, as my opponent says, psychological comfort and create a placebo effect without a better medical outcome. But I would say for psychological comfort, you should spend some more time with the patient, counsel properly, spend good time with them, and make them understand how to go ahead with this protocol. Then patient will definitely going to accept that protocol. So standard approach often suffice for many patients. And so I would like to conclude that personalization of ovarian stimulation is often more hype than necessity. Many studies shows no significant difference between the personalized and the standard protocol, and it should be applied cautiously as standard protocols can suffice for many patients. So keep it simple, stay safe, and low cost is the best thing. And so it's always better to standardize the protocol rather than going for a personalized protocols and individualizing the patient. Thank you very much.
Very nice. Thank you. I hand over to Professor Abha Majumdar ma'am and Dr. Shweta Mittal now.
Is Dr. Abha there?
Yes, she
Should
is.
we give rebuttal and
Can
then
you hear me?
Yes, ma'am, we can hear you.
I want the video also. Let
Yeah,
me see
Dr.
if I.
Shweta, rebuttal is fine if you,
yeah, I think let's have the rebuttal. Then we
Okay.
yeah.
Okay.
One minute of rebuttal.
So can I start?
Yeah.
Yeah. So as ma'am said that the psychological distress is not gone only by counseling and talking to the patient. Sometimes they might need something more than that. They might need some kind of medication and help. So that needs to be done. Number one. Number two, just to talk about the cost part, sometimes the total cost is even less if you are going for a personalized treatment. Like I gave an example, a young patient with a tubal factor or mild male factor does not need to go for a conventional IVF where you are giving 225 international unit, getting 12 to 15 eggs and forming 10 blastocysts and keeping them frozen for a long time. So the patient doesn't need to pay the cost of freezing. The patient doesn't need to pay for too much of, medication and all that. The most important thing is that personalization does not mean that you choose different kind of protocol. Personalization means that you are doing what is specific for that patient. For example, if she is a obese patient, you may go for a little high dose, but if she is thin or young age, you don't need to go for high dose. You can give a lower dose. If there is only mild male factor, you can go for a very mild stimulation. You don't need to, you can do even only Clomid cycles also. You don't need to go for. The problem with the experience and teaching is that once you explain the thing, it's not about at every step. You have selected the protocol, you have chosen the protocol, you have decided, and you give the guideline. So once you can train all the staff also, and it becomes easier, rather than, sometimes it feels that if you are not doing something, you are starting, for example, let's take example of Citrolix. It is a flexible protocol. If you make it a fixed protocol starting everybody on 8th day, there would be some patients who don't need Citrolix at all, too many follicles, PCOS, or there will be some patients where you will be cutting off the FSH unnecessarily by starting the Citrolix earlier. So again, I come back to the same point. Personalization is the need. It is not a marketing gimmick. It is you have to tailor made according to the needs of the patient, whether it is little low dose or high dose. There are so many protocols because of some reason, because everybody needs different thing. No two human beings are same, no two fingerprints are same, and couple already are unique. There is going to be a unique individual born by them.
Dr. Kokila, your turn.
Yes. I would say I don't say that it's a long protocol to be used or antagonist to be used. I would say that there should be a standardization of the protocol at your center so that it is very easily understandable by the staff as well as the doctor. And as my opponent said that you just make them understand one time so that they can follow. But like there is a frequent change of the staff nowadays. There are frequently doctors are getting changed. So how many times you are going to teach them? I think it will become a teaching centers for every 2 months if you are going to do that. Sometimes they stay for 2 months, sometimes they stay for 6 months. So like your all energy will get wasted to teaching them. And so rather than that, you just make a standardized protocol for your center, make them understand all the staff as well as the doctor that we have to follow these things. And if there is a problem arise in after doing a standardized protocol, then you can make an individualization of that patient because that is a need of these protocols. And because standardization is required and single protocol will definitely work nicely so that you can get our main purpose of doing IVF is to get a good number of oocyte, good number of embryos and prevention of islet surge. If these three things is happening with any of the protocol, just make standard protocol for your center in that way and keep doing it. If there is a problem or failure, they are definitely a separate case. And for them, you can just add on whatever is required. That is what I would say. And so making the simple IVF, it becomes easy for the newcomers also to learn and for staff also to manage. And there is no much complex and there is no problem of given wrong injections given in a wrong time. All that disaster may not happen.
Okay, so it was a very nice debate, and it was quite unequal in the sense that Kokila was given a topic which is very difficult to defend. You say in today's world that now the only thing is in the nomenclature, standardization and individualization are two parts of the same thing. Any individualized treatment should be standardized first.
Yes.
After standardizing your protocol, then you bring in the individualization of doses. And Kokila, I can understand how difficult it must have been for you to get into a 5-star restaurant to see.
I definitely
just a minute.
different protocols.
Just a minute. Let me complete. It was difficult, but please do not treat individualization as calling the patient and giving him a very special treatment. It is not giving a special treatment to the patient. Avoidance of complication is our foremost duty. The Hippocratic Oath says cause no harm. So our first thing is that you individualize your doses only. Protocol you standardize. No one is saying you must have non-standard protocols. You go for antagonist, agonist, whatever your standard protocol is. You have to individualize the doses to prevent complications and to have less repetitive cycles. When you say mild stimulation for an older patient, I don't understand. Why? Because number of oocytes required are more to give her one euploid blastocyst. Whereas for a younger one, if you say mild stimulation, I understand. Because even 2-3 oocytes can give her 1 or 2 euploid blastocyst very easily. So, these are small things that we have to keep in mind. The age of the patient, the weight of the patient, her ovarian reserve. I'm not saying you rely on AMH, You rely on AFC, but you can rely on her previous response at least. Don't give her a chance for hyperstimulation. This is all what individualization means. It is different from standard protocols. You have a standard protocol, you follow that, just individualize the doses here and there so that your patient has minimal complications and minimal need for repetitive cycles. Those who are proponents of mild stimulation or natural cycle, they know that they will have to undergo many cycles. In that case, please make the cost of the IVF treatment also half or less than that if you want to give them cost benefit, because only giving them cost benefits of the injection makes no difference. They will have to go through 3 or 4 cycles to get the same number of embryos what they get in one your standard stimulation. So both of you have justified very well, but Kokila was given a very difficult topic according to me. Now Shweta will go ahead.
So when I understand what is individualization, so in today's scenario, sitting in 2024, I categorize my patients into 3 categories: hyper responder, normal responder, and poor responder. I have already individualized the treatment because I have categorized them in 3 categories. And then I have something like I call my donors as hyper responders, right? I'm not going to be giving a standard treatment. But if you talk of a standard protocol, then yes, in this category, there is a standard protocol that I've decided. For my hyper responder, I will give 150 unit. For normal responder is the 225 unit, and poor responders get a higher standard dose of gonadotropin. So I take it that way when I think of individualization. What you really beautifully summed up, Dr. Kokila, because when we hear individualization of COS, we say that it's a piece of cake you take away. Of course, everybody needs an individualized, but what you beautifully showed, that adding progesterone induced may not fare better than an antagonist. Adding clomiphene may not fare better. Adding letrozole may not fare better. But when I think of individualizing a treatment for like a cancer survivor or for patients with estrogen dependent situations, then yes, the word individualization will come. We are giving the standard protocol, but there we will individualize because their letrozole is recommended. Or if we say hyper responder, there we will individualize because we will give an agonist trigger and we will always do an antagonist cycle. So the data what you showed was of 2015 and which is 8 years back. So we evolved. So I would suggest that in the standard protocols, we need to individualize. This is exactly this way what we keep doing. Having a standard protocols in a unit is good because that helps in standardization of your treatment or patient care. But individualizing in your standard care is something what you need for maybe 10 to 15%. For example, you take a hypogonadotropic hypogonadic girl, you need to individualize because you need to give her an LH from the beginning. But when we talk of poor responder, your LH may work, may not work, because the proponents of LH will say it works, the proponents of FSH will say it doesn't work. But there are certain categories where this individualization will work, and there are certain categories where standardization will work. But the way Dr. Kokila defended it was so strong that I loved it. So I personally love the defense. I love the defense. So, so this topic I don't think can have a judgment. Yeah, it cannot have a judgment. But
it was
Dr.
very difficult.
Yeah.
In today's
So that's why I put the first 2 slides saying that so much of individualization is going on. As such, myself also practicing in that line only. But because I have to, argue. So
it was a very unbalanced debate.
Yeah.
The debate was already tilted towards individualization because we all understand the need for it. Yes, maybe if this debate was 20 years ago, say in the year 1998, it would have been an appropriate debate.
Right.
Because then there was nothing as individualization. It was one shoe fits all.
Right.
So very nicely defended, both of you, Nisha. You had brought out very good points.
Thank you, ma'am. Thank you, Dr. Bunny.
Thank you.
Thank you, ma'am.
No, thank you so much. I think this
you brought the difference.
Sorry.
Yes, ma'am.
I'm saying thank you. It was lovely to hear the debate.
Yeah, and both of you win.
Okay,
Thank you,
thank you so much.
Thank you.
Though even Kokila understands that individualization is required, and we have to advance from whatever we are to getting better and better. Not for anything else. Patient safety is the most important thing. Whether you do 10 cycles, you do one cycle of hyperstimulation, and that patient is off forever from IVF. All right. Thank you.
Thank you. Thank you so
Bye.
much, Professor Abha ma'am and Dr. Shweta. I think this is very nicely highlighted individualization and standardization. So I
Yeah.
think especially for, juniors and everybody to understand, I think very nicely, it has clearly demarcated two things. No, thank you so much for beautiful debate. And thank you,
Dr.
Abha
Puneet,
ma'am,
giving
for
us this
your
opportunity.
wonderful advice and explaining the initial bit that, there are standards, but individualism doses is very important. So thank you for that. And thank you, Dr.
Doses and small little bits changes here and there, where you add something to prevent a complication. Everything is with the intention of preventing. You also give low molecular weight heparin to people who come with a history of DVT. So you have to individualize according to a patient, but standard protocols are the best. Don't deviate from standard, whether it is agonist long or antagonist short.
Yes. Thank you so much.
Thank you. Thank you, Dr. Shweta, as well.
Thank you, Dr. Kokila.
Thank
Bye.
you. So just before we end, I would now request Dr. Shweta Mittal, Secretary General IFS, to say a few words before we finally end.
Thank you, Dr. Puneet. It was wonderful. All the SIGs are doing wonderful webinars. Whenever I get to attend them, I'm there for a lot of them, and excellent programs are curated. Just before I end, being the organizing secretary of Fertivision for this year, 2024, which will be held at Ahmedabad on 6th, 7th, and 8th of December. So we invite you to be a part of the program, either as faculty, delegate, debaters, presenters. There's lots and lots of opportunity to present your original work or interesting case histories, whether it be oral presentations or posters, and with lots of awards to be won. And then looking forward to good fun. So please come and attend and become a member of Indian Fertility Society. All the details are available on the website. Thank you, Dr. Puneet, for this.
Thank you. Wonderful afternoon. It was a kind of a great academic session. Thank you, Dr. Renu Mishra ma'am. Thank you, Rajapriya, Dr. Nisha, Dr. Kokila, and good verdicts by Dr. Abha ma'am and Dr. Shweta. Thank you so much for being a part, and thank you to wonderful delegates. There were a lot of questions and brainstorming which happened. So very glad to hear that everybody participated actively. Thank you for being a part of this webinar, and have a very good evening.
Thank you.
Thank you. Thank you, Puneet.
Thank you.
To everybody. But now I think we are off air. Is it? Are we still recording? No. No, not.
I think Karan, thank you to Karan also, I would say, our ITT and concept team, who was very kind in organizing this IT setup for us, because we are not very good in IT.
This is international conferences, the team.
Concept, isn't it? Concept
international conferences, yeah.
Can I stop the video, ma'am?
Yeah.
Thank you, Karan.
Conferences International, they said.
Conferences International.
Conference International, yeah.
Okay, thank you.